So welcome back, friends. Now we are going to discuss the next topic on venous system. Okay, in vascular system, we have finished artery system. Now we are going to discuss on venous system. So in venous system, the major topic are only two. One is varicose vein and another is deep vein thrombosis. We are going to discuss only about these two. Let me discuss the basic anatomy needed for this topic. I'm not going to discuss in-depth anatomy, but what is anatomy needed for me to understand this topic? So please understand, this is deep venous system, femoral vein, popliteal vein, anterior tibial vein, posterior tibial vein. So this is anterior tibial vein, this is posterior tibial vein, this is popliteal vein, this is femoral vein. So this is deep venous system. This is a deep venous system, and this is a fascia. This is the fascia, deep fascia. And now I'm drawing the superficial venous system on the medial side. So this is a great saphenous vein running on the medial side. This is great saphenous vein. So this is great saphenous vein, GSV. So GSV enters the femoral vein at SFJ, saphenofemoral junction. At saphenofemoral junction, the great saphenous vein enters the femoral vein. Similarly, on the medial side, there is short saphenous vein, which is not so important for our discussion, which joins into the, on the lateral side, there is short saphenous vein joining into the popliteal vein. And this is the fascia. So please understand anatomy I'm drawing, very important because you are going to have few MCQs in medial level itself from this. So great saphenous vein runs medially above the fascia and enters the fascia and enters into the saphenofemoral junction. Okay, similarly, short saphenous vein runs laterally and enters the popliteal vein, that is saphenopopliteal junction. So I'm now going to draw the perforators. There are perforators. So perforators are very important for your exam. So perforators are those vessels or veins which are entering from superficial vein to deep vein like this. This is one perforator. So this perforator is present in the middle of the thigh, mid-thigh level, known as adductor canal perforator. Adductor canal perforator. What is the name of this? So just remember the number of perforators I'm telling. On medially, we have adductor canal perforator known as Hunterian perforator. So this is the first perforator I want you to remember. Hunterian perforator is seen in the mid-thigh level. And above the knee, there is an above knee perforator like this. So there is above knee perforator above knee perforator is present, above knee. And there is below knee perforator present. And this is below knee, and these are ankle perforators. Ankle perforators. Now let us tell the names of each. So one is adductor canal perforator or Hunterian perforator. Above knee perforator is known as what? Below knee perforator is known as what? And lower leg perforators are known as what? And there are small inconstant ankle perforators. So totally 5 perforators on the medial side. I will tell you what are where all they are connecting, but most important thing you should know is the perforators between superficial venous system and deep venous system. Hunterian perforator is in the mid-thigh level. Above knee perforator is also known as, the names may be asked in your exams: Dodd, Boyd, Cocket, May or Custer. So these are the various named perforators. So please don't forget the names. Hunterian perforator is mid-thigh, above knee is Dodd, below knee is Boyd, lower leg is Cocket, ankle perforator is May or Custer. May or Custer is an ankle perforator. So now you can get an exam. What are the veins which are connected by each perforator from anatomy? So please, I have already told you, Hunterian perforator connects between great saphenous vein and femoral vein. Okay, great saphenous vein and femoral vein. So Dodd is also between great saphenous vein and femoral vein. Boyd is so here at this point I want to tell you there is a division of great saphenous vein. The great saphenous vein gives a branch known as posterior arch vein. This vein I'm drawing is posterior arch vein. So posterior arch vein. And below knee perforator is a perforator from great saphenous vein to this vein is posterior tibial vein. Between the posterior, this is posterior tibial, this is anterior tibial. So this below knee perforator is between great saphenous vein to posterior tibial vein. So lower leg perforators, the lower leg perforators what we are discussing as Cocket and Dodd is between posterior arch vein and posterior tibial vein. This is between posterior arch vein and posterior tibial vein. Please remember this point. So let me tell you again. I have told you Hunterian perforator. Hunterian perforator is a mid-thigh perforator. Dodd is above knee. Boyd is below knee. Cocket is lower leg perforators. May or Custer are ankle small perforators. So now let us tell about the connection. Where are they connecting? Hunterian perforator connects superficial venous system, deep venous system, from great saphenous vein to femoral vein. Dodd is great saphenous vein to femoral vein. Boyd is great saphenous vein to popliteal vein, below knee. Boyd is below knee perforator between great saphenous vein and popliteal vein. Cocket is between posterior arch vein, a branch of great saphenous vein, posterior arch vein to posterior tibial vein. So this is one thing different between posterior arch vein and posterior tibial vein. If you see here, this is posterior arch vein, this is posterior tibial vein. Between these two are seen Cocket perforators or lower leg perforators. Or Cocket perforators. So this is the basic anatomy I want you to know before going into discussion on varicose veins. So first topic I'm going to discuss is on varicose veins. So varicose veins, why they develop? The basic pathophysiology behind the development of varicose veins is very simple. From the picture you can see this is deep venous system. So just now I'm drawing roughly, and this is superficial venous system. Why there will be dilated varicose vein? The mechanism or the causes are, if there is a deep vein thrombosis, number one. If there is a deep vein thrombosis, the superficial veins cannot drain and results in varicose vein, number one. If there is a incompetence of this wall, saphenofemoral junction incompetence, there can be varicose veins. Saphenofemoral junction incompetence can cause varicose veins. And if these perforators are incompetent, there will be varicose veins. So the causes of varicose vein, the pathophysiology behind the varicose vein is the DVT is present, saphenofemoral junction is incompetent, perforator is incompetent. When this three problems is there, you get varicose vein. So these three problems are detected by simple clinical test itself. So clinical test itself is enough. There are many clinical tests to differentiate whether it is DVT or saphenofemoral incompetence or perforator incompetence by simple clinical test itself. So there are so many tests I'm going to discuss soon. So before going to the test, let me discuss the clinical presentations. What are the clinical features of varicose veins? The patient presents to you with a dilated tortuous veins. Please don't forget there will be dilated tortuous veins of more than 3 mm diameter is known as varicose veins. Apart from this, there will be skin stretching. Skin will be stretched. The skin will be stretched and there will be eczema. There may be pigmentation, and there may be ulcer on the medial side of the foot. Ulceration may be present, and the skin can have loss of hair. All these are various features of increased lower leg pressure, causing due to increased venous pressure. There will be all these skin changes, and there will be brittle nails. All these findings you should look, and very important finding you should look in the lower limb is lipodermatosclerosis. Lipodermatosclerosis is a skin pigmentation. Lipodermatosclerosis is a skin pigmentation due to Increased venous pressure resulting in rupture of RBC, releasing hemosiderin. Please remember, due to hemosiderin deposition, due to increased venous pressure, the RBCs will rupture and they will cause release of hemosiderin pigmentation that results in lipodermatosclerosis. And what are the other clinical features you see in a varicose vein are you can see telangiectasias. So I'm telling you what are the clinical presentations of varicose vein. Telangiectasia, reticular veins. So telangiectasia means the vein size is less than 1 millimeter. Reticular vein is 1 to 3 millimeter diameter. So less than 1 millimeter diameter is telangiectasia, 1 to 3 millimeter diameter is reticular vein. Varicose vein is more than 3 millimeter diameter, more than 3 millimeter diameter. So all these findings are seen on clinical examination. On just inspection itself, you can find out all these things. So examination of varicose vein is a high yield topic for final MBBS students. Aims clinical test, image based or video based questions, and you can even get a national board exam about the various tests. So please understand the tests I'm going to tell you now one by one. So various tests to be understood. So I have to find out whether the patient is having saphenofemoral incompetence. I have to find out whether the patient is having perforator incompetence. I have to find out whether the patient is having DVT. So what are the tests for each? Saphenofemoral incompetence is detected by Trendelenburg test 1 and Morrissey's cough impulse test. Morrissey's cough impulse test. So Trendelenburg 1 test and Morrissey's cough impulse test. I'm going to explain everything soon. Don't worry. And you'll be seeing these videos in clinical image based section in our document. We have a clinical based discussion in which I will demonstrate the videos as clinical examination itself. So perforator incompetence, Trendelenburg 2 test, multiple tourniquet test, Pratt's test, Fegan test are all used for perforator incompetence. For DVT, what are the tests? Perthes test, modified Perthes test. These are the two latest tests. Perthes test and modified Perthes test. Old tests are Homan sign, Moses sign, and Pratt's sign. Okay, Pratt's sign. So this is not Pratt's test, this is Pratt's sign. So let us discuss one by one now. Okay, now let us discuss one by one. Trendelenburg test. Please understand how we are doing each test because they may ask you to demonstrate those tests. Trendelenburg test. I'm drawing you the clinical examination. So please understand the clinical examination. I'm going to demonstrate you the clinical examination by drawings. So now this is saphenofemoral junction, which is present 4 cm below and lateral to the pubic tubercle. Saphenofemoral junction is present 4 cm below and lateral to the pubic tubercle. Now at this point you tie a tourniquet. So this is either you can tie a tourniquet or in a Trendelenburg test we used to compress it very tightly with the thumb. At that point, make the patient lie down, reduce all the varicose veins, compress at the saphenofemoral junction and make the patient stand. And the moment you take the finger out, you can see the veins filling very fast from above downwards. This is Trendelenburg test 1. On taking the finger out, you can see the veins filling from above downwards. This is Trendelenburg 1. In Trendelenburg 2, I will keep the finger, I will not take it out. I will keep it tightly. So as I'm keeping it tightly, I can see slowly the veins filling from below upwards like this. What is the reason? So Trendelenburg 2 is perforator incompetence. So Trendelenburg 2, perforator incompetence. Trendelenburg 1, saphenofemoral incompetence. In which test I will not take the thumb out is test 2. In Trendelenburg test 1, I will take the thumb and see how it gets filled up from above downwards. In Trendelenburg test 2, I will not take the finger out. It will be tightly compressing the thigh. So this is Trendelenburg 1 and 2. So 1 is for saphenofemoral incompetence. 2 is for perforator incompetence. Okay. So now I'm going to demonstrate the next test. Multiple tourniquet test. So multiple tourniquet test to understand, please understand, this is saphenofemoral junction. Okay, this is saphenofemoral junction. Then what are the other perforators? This is mid-thigh perforator, this is above knee perforator, this is below knee perforator, this is ankle perforators. Now I am going to tie the tourniquets at multiple level. First tourniquet is tied below the saphenofemoral junction. First is below SFJ. And usually this is not tested separately, like which is not tested separately is this. Another perforator is ligated at the middle of the thigh, at the level of below the knee like this. Another is tied here. So like this, you can tie at multiple spots and you can see between which two tourniquet there is varicose vein appearing. For example, if there is I have tied it one below SFJ, second below knee. If there is veins appearing in this place, it means what? There is either a anterior perforator incompetence or above knee perforator incompetence. Below the knee, I have made a tourniquet below the knee. Now, if it is forming veins here, it is below knee perforator incompetence. And I have tied another tourniquet at a lower level, and if there are veins formed here, it is due to lower leg perforator incompetence. This is multiple tourniquet test to look for perforator incompetence. Please don't forget, these are all simple tests. When you open DAS and read, everything is explained in detail. DAS, you can see everything is explained in detail. So now we're going to another important test for DVT that is known as Perthes test. Perthes test. The concept of Perthes test is, since there is a deep, please understand, since there is a deep vein thrombosis, now only the superficial veins will drain the entire blood. Since there is a deep vein thrombosis, it's only the superficial veins which are draining the entire blood. So now if I'm going to put a elastocrip bandage like this in the entire limb, tight elastocrip bandage like this, if I'm going to apply, I'm compressing the superficial veins. So now if I ask the patient to walk, already deep vein thrombosis, now superficial veins is compressed, so patient will complain of what? Complaints of severe pain on walking. So this is a test to detect DVT, but problem is it is a subjective test. Patient will tell I'm having pain, sir. That's all. So therefore it is a subjective test. To find out whether there is a DVT present or not, we have made a test known as modified Perthes test. So modified Perthes test is an interesting test. Let me see who is going to answer this question correctly. If you are answering, you have done your final year very good, and you have had an excellent clinical knowledge in your final year. So now I'm going to do one more test, modified Perthes test, in which I will not reduce anything. I will not reduce any veins. Just I will put a tourniquet very tightly below SFJ. I will put a tourniquet below SFJ very tightly, and I will ask him to walk. If he is going to walk, yes, already dilated varicose veins will become more dilated, and you can see clinical examination. You can see dilatation of the veins will be seen. The dilatation of the veins will be seen, and the patient also will be complaining of pain. So it is both subjective as well as objective. Subjective plus objective, both are positive in this test. It is both subjective and objective. So please remember, the patient will complain of dilatation plus pain together. It is subjective and objective together. So what is the prerequisite for the test? This is the question I'm telling you. What is the prerequisite to do this test? Can you tell me? Final MBBS students, if you are there, this is a classical question asked in Viva exams, the final year clinical examination. To do this test, what must not be present? This is a modified Perthes test to detect DVT. To do this test, there should not be no perforator incompetence should be there. Okay, to do this test, perforator incompetence should not be present. Why? Because if perforator incompetence is present, then you will not get the dilatation and pain. If there is perforator incompetence is present, the dilatation of the veins and the pain will not happen. So therefore, to do this test, perforator incompetence should not be present. If perforator incompetence is present, that perforator will bypass some of the vessel veins, blood flow like this also. That also is possible. So to do a modified Perthes test for DVT, perforator incompetence should not be there. Please don't forget modified Perthes test. So coming next to the Pratt's test. What is the use of Pratt's test? I told you for whom? Pratt's test is used to look for perforator incompetence. Look for perforator incompetence. Now you see, I want to look out where all the perforators are incompetent. So what I will do is, now I will start putting a elastogrip bandage from below upwards like this very tightly. I'm putting a elastogrip bandage below upwards tightly like this and break completely empty the veins. Now I will take another elastogrip bandage and I will start applying it from above downwards like this. As I am applying it from above downwards, I will remove the elastogrip bandage from the previous bandage will be removed from below upwards. Now as I am doing like this, and if this is getting removed as such, we can note the bulging of the perforators. The bulging perforators will look like this. So this is known as Pratt's test. To understand, if the examiner asks you to do Pratt's test, you need 2 elastogrip bandage. You need 2 elastogrip bandage for which test is Pratt's test. And at this point, make a mark. Make a mark. Wherever there is a blowout coming, you make a mark. This is blowout. And after completing this test, after removing all these things you remove it, and wherever there is a blowout, if you palpate, what you will see that the deep fascia will have a pit. The deep fascia will have a pit. Will have a gap. This test is known as Fegan's test. So the deep fascia will have a gap. That gap is known as Fegan's test. Okay, this is one more test. Fegan's test and Pratt's test are used to detect perforator incompetence. So there's one more test known as Swartz test. Swartz test. Remember the book name Swartz. In a Swartz test, what I will do is, if I'm seeing a long varicose veins like this, if I'm seeing a long column of varicose vein like this, I will tap below. At this place, I will tap the vein and I will feel the impulse with another finger in the upper level. So if I tap, I will feel the impulse. That is due to valve incompetency. The entire column of vein, the entire column of varicose vein, the valves are incompetent. So valves incompetency can be detected by Swartz test. When I tap down, I will feel the impulse up. This is Swartz test. Another test is Morrissey's cough impulse test. So Morrissey's cough impulse test is nothing but like a hernia test. We keep the finger on the saphenofemoral junction, ask the patient to cough. You can see that Morrissey's cough impulse positive. In fact, before doing the Morrissey's cough impulse itself, you can see there is a bulge in the saphenofemoral junction known as saphenobarics. Saphenobarics is a bulge present in the saphenofemoral junction. Bulge because of the weakness. There is a bulging vein that is known as saphenobarics. Please don't forget Morrissey's cough impulse test. So finally comes the DVT test. Hohmann sign. Hohmann sign is forceful dorsiflexion of the ankle. Moses sign is forceful compression of the mid calf. Forceful compression at the mid calf level. So both these tests, what problem can happen? Both will cause severe pain, and these both can stimulate pulmonary embolus. So these two tests are no more advised hereafter. Contraindicated. So therefore, if at all you want to do local examination, you can do Pratt's sign, in which in the cough we don't compress posteriorly, we just compress and see laterally for the tenderness. Lateral compression of cough. Lateral compression of cough is known as Pratt's sign. So please remember, Pratt's sign, we do lateral compression of the cough. So this is Hohmann sign, Moses sign, Pratt's sign. So let us review now. So what are all the tests done for saphenofemoral incompetence? Can you tell me saphenofemoral incompetence? Trendelenburg. So Trendelenburg 1, in which we take the finger out. Then Morrissey's cough impulse. So these are the 2 tests for saphenofemoral incompetence. What are the tests for perforator incompetence? Trendelenburg 2. What else? Trendelenburg 2. Fegan test, looking for the gap in the fascia. Pratt's test, in which we use 2 elastogrip bandage, multiple tourniquet test. Multiple tourniquet test. And what is the use of Swartz test? Swartz test is to look for long column of incompetent vein. Long column of incompetent vein is diagnosed with the help of Swartz test. And DVT, already told you, the DVT classical clinical examination test are Perthes test with 1 elastogrip bandage. Perthes test. It is a subjective test. Modified Perthes test is subjective and objective. There should be no perforator incompetence to do this test. So Perthes and modified Perthes test are the 2 tests of these patients. Okay. So now coming to the CEAP classification of varicose veins. CEAP classification of varicose veins. Clinical, etiological, anatomical, pathological classification. Clinical, etiological, anatomical, pathological classification. Every year they are asking question from clinical classification. I want you to remember clinical. Even if you are not going to remember other things, no need to worry. But clinical C1, C2, C3, C4A, C4B, C5, C6. There are 6 types of clinical classification. Be very simple. Clinical 1 is there is telangiectasia, means less than 1 millimeter veins or reticular veins. C2 is varicose vein, more than 3 millimeter. It is more than 3 millimeter. This is 1 to 3. This is less than 1. C3, there is edema in the leg. C4 is pigment. I told you, there will be pigmentation or eczema in the leg. C4B is asked last year. C4B is lipodermatosclerosis or atrophy blanchi or lipodermatosclerosis. Atrophy blanchi. It's another type of skin change. Atrophy blanchi and lipodermatosclerosis. And C5 is an healed ulcer. Healed venous ulcer. C6 is active venous ulcer. C6 is active venous ulcer. Please don't forget this clinical classification. C5 is a healed venous ulcer and C6 is an active venous ulcer. I'm going to discuss venous ulcer separately, but remember this is clinical classification. C1, C2, C3, C4A, C4B, C5, C6. This is clinical classification of these patients. Now coming to etiological classification. Etiological. So etiological is very simple. EP is primary. Etiology is primary. EC is congenital. Okay. ES is secondary. Only 3 types. So primary, in which cause is actually not known. So congenital, there is some congenital pathologies like clipper tramine syndrome, all those types. Secondary is ES, due to following a DVT. So etiological. Now anatomical. Anatomically, we have to say which system is involved. So anatomical, AS is superficial veins. AP is perforators. So involvement of perforators. AD is involvement of deep veins, like deep vein thrombosis. Simple. Superficial vein, perforator, deep vein. And comes pathological, pathophysiological classification. So this and all is not asked in exam, but clinical is asked in exam. Please remember, pathological can be due to reflex. PR. PO is due to obstruction. PRO is due to reflex plus obstruction. So PRO is due to reflex as well as obstruction. This is known as clinical, etiological, anatomical, pathological classification. Okay. So please don't forget clinical classification, etiological, anatomical, and pathological classification. So this is about the clinical, etiological, anatomical, pathophysiological classification. Please don't forget it. Now coming to the risk factors of varicose vein. Why a patient develops varicose vein? So there may be family history. There may be a family history. Patient may be doing a work which is long-standing, like a teacher, like a surgeon, like a bedroom worker, like a conductor. All these guys long-standing job. DVT, following a deep vein thrombosis, following defective valves. The valves are having problem. Defective valves. Some mass in the abdomen. Pregnancy. Usually the pregnancy, we can see so many patients coming with sudden varicose vein in the pregnancy. We have to wait. Most of the time they resolve. Okay. And one congenital syndrome I want to tell you causing varicose vein is, what is the name of the syndrome? Congenital cause of varicose vein. I'll show you the image. That is Klippel-Trenaunay syndrome. Klippel-Trenaunay syndrome. Klippel-Trenaunay syndrome is characterized by number 1, fourth vein stain. The features of this condition are fourth vein stain, and they will have lateral varicose vein, not medial. It is an anomaly not involving the medial side. It is an anomaly involving the lateral varicose vein. Lateral varicose vein will be present. Lateral varicose veins will be present full length, and there will be limb lengthening or limb hypertrophy. So port vein stain, lateral varicose veins, and limb lengthening are the features of Klippel-Trenaunay syndrome. So these are some of the features of predisposing factors of varicose veins. Now tell me, what are the complications of varicose vein? The major complication of varicose vein, the most common complication of varicose vein is skin-related complications. Skin complications. So the skin can develop what? The skin can develop eczema. The skin can develop pigmentation. The skin can develop lipodermatosclerosis. The skin can develop atrophy blanchi. And the skin can cause severe fibrosis, and the leg can go into a shape like this. What is the name of this complication? Looking like this. Inverted champagne bottle appearance. This is known as inverted champagne bottle appearance. So this appearance can also happen. Inverted champagne bottle appearance can also happen. And very important skin complication is skin ulcer. Where is it seen? Ulcer. And there can be bleeding from the varicose vein. So in this skin ulcer, I want to discuss in depth. So I want you to know more about the skin ulcer. So please remember, this is a thumb. These are the 4 fingers. On the medial malleolus, exactly on the medial malleolus, the venous pressure is very high, and there results an ulcer known as varicose ulcer. Also known as venous ulcer, varicose or venous ulcer. The most common site is gaiter area. Gaiter area is the area where we put that thing while we are doing horse ride, the gaiter area. During a horse ride, that clamp is applied in this area. So the gaiter area, you get a venous ulcer, and it is a sloping edge. It has sloping edge. The floor is covered by granulation tissue. Base is formed by tibia. Floor is formed by granulation tissue. Base is formed by tibia. All these things we discussed in skin lesion chapter. And this ulcer can bleed. This ulcer can bleeding can happen in this ulcer. This ulcer can cause periostitis tibia. Periostitis tibia. This ulcer can erode into the underlying bone and cause periostitis tibia. This ulcer, because of pain, the patient may walk with a tiptoe. That is known as equinus deformity. Because of the pain, he starts walking like a equinus, like a horse. That is known as equinus deformity. So bleeding, periostitis tibia, equinus deformity can happen. And long-standing, this varicose ulcer can go for Marjolin ulcer also. This can go for Marjolin's ulcer. Already we have discussed. It is a type of squamous cell cancer. It is a type of squamous cell cancer. So long-standing varicose veins can go for Marjolin's ulcer. So these are the various interesting complications in varicose veins. But most of the patients nowadays, they are coming for cosmetic reasons itself, especially females. They come to you for cosmetic reasons itself. So these are all various complications. So venous ulcer is the only complication we commonly see, and mostly these venous ulcers are managed by a special method which we are going to discuss, known as Bisgard method of management. We'll be discussing it later. Bisgard method is a method to manage this venous ulcers. We'll discuss about it later. So now you have clinically diagnosed the patient is having some problem, that is varicose veins. Now what we are going to do are the investigations specific for varicose veins. So the first important investigation we all do is the vascular will be always having a handheld Doppler in their packet. Handheld Doppler. Handheld Doppler is only will catch up the sound. It is not catching anything else except the sound. If there is an obstruction, if you keep that Doppler on this place, if there is an obstruction, you will have a continuous sound. There will be continuous sound will be present. So if there is an obstruction, there will be sound positive. Sound will be heard. If there is a compression, we will be having a sound. And if I am compressing the cough, if we keep this handheld Doppler in the septum junction, if I compress and leave it, so I can hear the reflex sound as a whoosh. The reflex sound is heard as whoosh sound. Whoosh sound is heard as the flow is going inside. The moment I release the cough, I can again hear the sound back. So the sound is heard on compression and on release. Compression and release, I can hear this whoosh sound at saphenofemoral junction. This is one method to find out saphenofemoral incontinence. So this is handheld Doppler, which is actually a OP procedure. But anyhow, we have to do investigation of choice. Color Doppler, also known as duplex scan. Known as duplex scan. We have to refer the patient to the radiologist for a duplex scan. So a duplex scan, if there is a normal antegrade flow, if there is a normal antegrade flow in a vessel, the duplex scan will show the color of the flow as blue. Normal flow is blue color. Normal antegrade flow is blue color. So now I keep the duplex in the saphenofemoral junction. As it is normally flowing, there will be blue color seen. If I am compressing and leaving, and if there is a reflex, if the reflex color is what? I can see the red color. If there is a red color coming up in the color Doppler, it is typically a reflex or incontinence. Reflex is given as a red color. Okay, incompetent vein will have reflex, and especially with this color Doppler, we get an appearance like this in the saphenofemoral area, known as Mickey Mouse sign. Mickey Mouse sign. In Mickey Mouse sign, what is this face stands for? The face is femoral vein. The lateral ear is femoral artery. Medial ear is saphenous vein. Great saphenous vein forms the medial ear. So you can see that this area you can inspect and you can see the reflexes directly. You can see the reflexes. So the medial most ear of Mickey Mouse is great saphenous vein. The lateral ear is femoral artery, and the face stands for femoral vein. So this Mickey Mouse sign is another investigation. So also mainly the duplex scan is mainly done to rule out DVT. We have to rule out DVT. We have to mark the perforators. So we'll mark the perforators also with the help of this. So to rule out DVT and to mark the perforators, all varicose vein patients are subjected to duplex scan. Okay, please remember this point. All are subjected to duplex scan. Coming to the management of varicose veins. Management of varicose veins. Even before the varicose vein is formed, people who are working in a long-standing places, they have to start using compression stockings. There are compression stockings available to prevent DVT also, and even to prevent varicose veins. And there are also compression stockings available which for varicose veins and venous ulcer. So in this, which can be asked for you, is there is a British classification. I want you to remember British classification of stockings. According to British classification of stockings, we have class 1, class 2, class 3 stockings. There are three stockings according to British. So this gives a pressure of 14 to 17 millimeters mercury. This gives 17 to 24 millimeters mercury. This gives 25 to 35 millimeters mercury. This is from William now. So what are the stocking pressures we use? So 14 to 17 is class 1 stocking. Class 2 is 17 to 24. Class 3 is 25 to 35. Usually we use 25 to 35 for established varicose veins and for venous ulcers. For venous ulcers as well as for established varicose veins, we should use class 3 stockings. 1 and 2 are used as prophylactic stockings. Before the varicose vein is formed or in the early stages of reticular or thread veins, we can use this. Okay, reticular veins, or in the case of telangiectasia, we can use class 1, class 2. So class 3 stockings are used for venous ulcers and varicose veins. And William very classically gives for venous ulcer, especially for venous ulcer, a management known as Bisgard method. So please understand, this is a separate short note for final years. Venous ulcer management by Bisgard method. So please understand what we do in Bisgard method is, so when the patient is simply sitting, we ask them to lift their leg. While sitting or lying itself, they should, leg lifting is advised. Leg lifting is advised. And we have to clean the ulcer with a clean water. Clean water or normal saline is used to clean the ulcer. If there is infection, you must do pus culture sensitivity and give antibiotics. If there is a bleeding, the bleeding from the venous ulcer is immediately stopped by doing what? No need to do any tight compression at all. Just lift the leg. Lift the leg, the bleeding stops. All this thing will be going on, and simultaneously we have to do very important thing, that is 4-layer bandage. This is an expected MCQ. 4-layer bandage should be applied to prevent this, to heal this venous ulcer. What is the 4-layer bandage? The first layer is made up of cotton wool. We just rotate all around the leg, cotton wool only, cotton wool. The second layer is your normal elastocrete bandage, cotton elastocrete bandage. We put a cotton elastocrete bandage as a second layer. Third layer, we have to put an elastic tight, another one tight bandage, elastic bandage. And fourth one, we have to put a cohesive bandage. I will show you the image. It is totally 4 layers. First layer is cotton wool. The last layer is a cohesive bandage. So with this 4-layer bandage, in the case of varicose vein ulcer, we have to give pressures very high. 35 to 40 millimeters mercury is given. For an ulcer already formed cases, we have to give pressure more than 35. Please remember this. When there's already a varicose vein is formed, we have to give tight compression. But when you're going to give this much tight compression, I should rule out what? I should rule out the ankle brachial pressure index. So ankle brachial pressure index is normal value is 0.9 to 1. 1.1 is a normal value. If ankle brachial pressure index is 0.5 to 0.8, I will not use this much pressure. I will keep the pressure at 30 millimeters mercury only. So because the patient is not only having venous problem, he is also having a peripheral arterial disease. At that time, if I compress it very tight, then there will be other complications. So therefore, these patients I should modify it at 30 millimeters mercury. And if ABPI is less than 0.5, I will not do compression at all. I should first do revascularization of the artery. Revascularize the artery before doing anything else. So please remember, so there is 4-layer bandage applied in ulcer patients. First cotton wool, then a cotton bandage, then an elastic. Actually, this is the second one is not elastic cotton creep bandage, it's a cotton bandage. So keep your wool and with the cotton you roll it, then you put an elastic bandage, then you put a cohesive bandage. I'll show you the image, you understand. With this we will have a pressure of 35 to 40 millimeters mercury. The ABPI is 0.9 to 1.1 and ABPI 0.5 to 0.8. We have to modify it to 30 and less than 0.5 we should not use this. Elastic bandage should not be used at all. Okay, then we have to clean the ulcer and put a split skin graft for that ulcer. The venous ulcer will be healed with a split skin graft. Okay, so what are the managements now? Surgical management of varicose veins. Surgical management of varicose veins, the conventional treatment is, the conventional treatment you should understand. What is the conventional long years the treatment being going on is Trendelenburg operation. Trendelenburg operation. High yield MCQ for exams, please understand this Trendelenburg operation. So in Trendelenburg operation, what I'm going to do is, this is great saphenous vein, this is femoral vein, this is femoral vein. And from the femoral vein, we have the superficial epigastric vein, superficial circumflex iliac. Okay, superficial veins and all will be present like this. And there will be some other deep veins also, deep circumflex iliac, deep branches, etc. will be present. So what I should do in this place is, I have to first dissect this area. I will dissect this area very clearly. I will identify the saphenofemoral junction. I will ligate the saphenofemoral vein first. I will ligate the saphenofemoral vein as a flush ligation to the femoral vein. And also at the same time, I will ligate all the small tributaries present there, because they may form a collateral and that is one of the cause of recurrence. Ligate all the collaterals there, all superficial veins there. So all the superficial veins in that area should also be ligated. We should not miss any small superficial veins either from the great saphenous vein or from the femoral vein. All the branches should be ligated. Now after ligating, this is known as Trendelenburg operation, flush ligation of saphenous vein at the saphenofemoral junction and ligating all the tributaries. Now I will introduce a stripper from downwards. So from downwards, from the mid calf level, please remember mid calf level, I will insert a stripper like this. And I will tie this vein here and I will withdraw the stripper. This stripper is known as hoist pin stripper. So if I withdraw the stripper, the vein will come in my hand, the entire vein will come out in my hand. I should do this only up to mid calf level, not below this, because if I go below the mid calf level, I can injure the saphenous nerve medially. Saphenous nerve can be injured medially, sural nerve can be injured laterally. There will be sural nerve injury lateral, saphenous nerve injury medial. Please don't forget this point. So this is the completion of varicose vein operation. So while I'm doing a saphenofemoral incompetence, I should do flush ligation and I should strip the vein. And before doing varicose vein surgery, I must ensure there is no DVT, because if there is a DVT, if DVT is present, this surgery is contraindicated. If there is a DVT, this surgery is contraindicated because this is a superficial vein which is draining the blood. If you remove the superficial vein, the patient will die of venous gangrene. So if there is no DVT, only this surgery done. If there is a DVT is present, this surgery is contraindicated. Okay. And for the perforators, what do you do? Sometimes there will be perforator incompetence. No, this is a deep vein, this is a superficial vein, and this is the fascia, and these are the perforators. So the perforators can be ligated either below the fascia or above the fascia. Above the fascia is known as Linton operation, suprafacial ligation of Linton. Suprafacial ligation of Linton is one method. Below is known as subfacial ligation of Cocket and Dodd. And the latest operation is like a laparoscopic minimally invasive. We go beneath the fascia by means of minimally invasive instruments. We go beneath the deep fascia. We insufflate this and we clamp the vessels. That is known as subfacial endoscopic perforator surgery. Expected MCQ steps. Subfacial endoscopic perforator surgery. Subfacial endoscopic perforator surgery is like a laparoscopy. We go beneath the fascia and we clip the perforators. And which among this operation should not be advised for lipodermatosclerosis? The patient having lipodermatosclerosis, Linton operation is not possible at all. because the fascia and the skin are fibrous. You cannot do lengthen operation at all. So lipodermatosclerosis patients, we should do cocket and dot operation. We should do cocket and dot operation. So we cannot do suprafacial ligation of lengthen. Okay, please don't forget, suprafacial ligation of lengthen is not possible for those guys. Okay, there are new methods now coming up. One method is Trivex system. In Trivex system, what we do is, so just understand this. I will show you the images. We throw light subcutaneously by a special instrument to throw light subcutaneously. We can see the vessel veins. And now with the minimally invasive method, we use hooks to hook out the dilated veins and ligate it. So hook the dilated veins. Hook the dilated veins and ligate it by a minimally invasive method. This is Trivex system. And one more system which is now used, upcoming and very commonly used is foam sclerotherapy, foam sclerosants. So the sclerosants used under ultrasound guidance, we can inject this sclerosants into the dilated varicose veins. The sclerosants used are sodium tetradecyl sulfate. Sodium tetradecyl sulfate is most commonly used. Sodium tetradecyl sulfate, sodium morate, polydocanol, and ethanolamine oleate. Ethanolamine oleate, polydocanol, sodium morate are the various foam sclerosants we use. Sodium tetradecyl, sodium morate, polydocanol are the various foam sclerosants we use. And by the method of creating foam, I will show you with a three-way stopcock. Like this, with a three-way stopcock, they will use one syringe this side and another syringe this side and create the foam. This method is known as Tessari method. Tessari method of foam sclerotherapy. So please don't forget that method is known as Tessari method of foam sclerotherapy. But anyhow, replacing all these operations nowadays, the recent operations are what? So no vascular surgeons are nowadays not doing any of these operations. They are doing new operations known as endovenous laser ablation. Even Vedic has explained these operations for many pages. Endovenous laser ablation. Another operation is radio frequency ablation. Please don't forget these two operations: endovenous laser ablation and radio frequency ablation techniques. So endovenous laser ablation, they introduce a laser catheter inside the veins, and the laser of around 1470 nanometer is applied. 1470 nanometer is applied laser inside the veins, and that will coagulate the full vein and the dilated varicose veins. Without major surgery, the veins will be totally destroyed and the varicose vein will be cured. The main advantage of this laser is, by using this type of laser, the main advantage is any size vein can be ablated. Any size vein can be ablated. It can be used for any size vein, and it can be used for perforators also. These are the main advantages. It can be used for perforator incompetence also. And main advantage is it can be used for any size vein and any perforators also. And it is cheaper. The laser fibers are cheaper compared to radio frequency method. So cheaper cost. When you come to radio frequency ablation, this is now using electromagnetic current. They use electromagnetic current and they produce thermal energy. That produces thermal energy and burn out all the vessels. Here also we introduce a coil inside the vein. There is a preset cycle available here. So for here we have a preset value. Preset cycle value is available. Preset cycle of current application is available. So we pass it inside and we coagulate all the vessels. The major advantage in this RFA is advantages are there is a set standard protocol available. Set standard protocol available for ablation of the veins. Okay, and it is easy for the learners, for beginners. It is easy for the beginners. And very important, this is less procedure time. Less procedure time, and it is less painful also. It is less painful. So the main advantages of RFA are set standard protocol is available. So it is easy for the beginners or learners, and it is less procedure time and less painful also. And what are the disadvantages means of this question is an expected question. What are the problems with RFA? RFA, the disadvantages are RFA fiber is costly. Please remember, RFA fiber is costly. RFA cannot pass tortuous vein. It is not possible for tortuous veins. RFA not useful for perforators. So now you can understand why still people are using laser. So the another advantage of this RFA is you need not use laser protocol, because when you are using laser, all of them should direct all those things are no. The laser protocol not needed here. So there is laser induced damage is not there. So laser protocol is not needed. So laser protocol is not needed, so we can casually use this RFA. So in this, I am expecting this year, the following are the advantages of RFA except. The except will be RFA fiber is costly. RFA fiber is costly. RFA cannot be used on tortuous veins. RFA cannot be used on perforators. Whereas endovenous laser ablation you can use for any vein, any perforator, and it is cheaper cost. The problem with laser is we have to follow the universal precaution inside the chapter. The laser can damage the people. Okay, so let us see the images from this chapter now. So please remember, varicose vein is a high yield MCQ topic for you. So this is a picture showing you a dilated varicose vein with the perforators. You can see the perforator incompetence, below knee perforator. Here there is a perforator incompetence. There is a saphenous varix. All these things you can see. And don't forget the various perforators. Hunterian perforator is mid-thigh. Dod is above knee. Boyd is below knee. Cocket is lower leg perforators. Dod, Boyd, cocket. Hunterian, Dod, Boyd, cocket. You have to remember it frequently by telling. That only you will not forget this. So you can see the pigmentation, dilated tortuous veins. You can see the telangiectatic veins. Telangiectatic veins are less than 1 millimeter. This is reticular veins, 1 to 3 millimeter diameter. All these things are seen on this image. So all the incompetence test I told you, multiple tourniquet test for perforators, Perthes test for DVT. It is a subjective test. DVT subjective test. Therefore, we should use a modified Perthes test. Important prerequisite to do modified Perthes test is there should be no perforator incompetence. So Pratt's test, we need 2 elastocrine bandage, 2 bandage needed. Figon's test, we will palpate that defect. So Swartz test is look for venous incompetence. Morris is stopping pulse, deep vein thrombosis, all this test we have discussed. So please don't forget clinical classification. Clinical classification, C4B is lipodermatosclerosis. This question came in the exam. And C5 is healed venous ulcer. So C4B is lipodermatosclerosis, C5 is healed venous ulcer. Etiological, anatomical, pathophysiological classification. And this is a Klippel Ternay syndrome. You can see a patient having a fourth vein stain, lateral varicose veins. You can note very well lateral varicose veins. And this limb is lengthened. You can see the limb lengthening. So these are the features of Klippel Ternay syndrome: limb lengthening, fourth vein stain, lateral varicose veins. So this is a typical champagne bottle leg. You can see due to lipodermatosclerosis, the patient is having an inverted champagne bottle appearance. So this is a long-standing venous ulcer going for a Marjolin ulcer. So this is a typical equinus deformity. Because of long-standing defect, the patient starts walking like a equinus. So this is an image-based question you can get. This is handheld Doppler used to measure arterial blood pressures, also to measure the flow in the vessels. So this is a duplex scan. So you can see the duplex scan. Blue color is normal flow, red is retrograde flow. So Mickey Mouse sign. This question came in NEET 2020 as an image-based question. So saphenofemoral artery, saphenofemoral long saphenous vein, this is superficial femoral artery, this is common femoral vein. So this is femoral vein, this is femoral artery, this is long saphenous vein or short great saphenous vein. So management, this is a compression stocking available, and this 4-layer bandage. First you put a cotton roll, second you put a just wool cotton, you should keep as first layer. Second layer you have to use a cotton roll. Third we use a compression bandage. Fourth we use cohesive bandage. The fourth one is cohesive bandage. So this is 4-layer compression dressing for venous ulcer. So this is a typical Bisgard method of healing the venous ulcer. So please don't forget, this is saphenofemoral flesh ligation going on here. So we have hooked out the long saphenous vein and femoral vein, we are doing a flesh ligation. So this is stripping of the varicose vein done. So the various perforator surgeries. Linton is a suprafacial perforator surgery. So you can see sepsis going on here. Subfacial endoscopic perforator surgery. Going subfacially, we go and ligate the perforators. This is known as seps. So you can see this is Trivex. You can see the light is thrown and you can see the dilated veins. The dilated veins will be hooked and ligated. Trivex system. So this is foam sclerotherapy. This method of creating foam is known as Tessari method from Valian Law. This is Tessari method of foam sclerotherapy. So the foam sclerotherapy will be injected and we make a tight dressing like this. So this is endovenous laser ablation technique. You can see the laser fiber is passed inside and it will ligate any size vessel. Perforator also can be ligated. So please don't forget the differences between EVLA and RFA. EVLA and RFA. Okay. Next we are going to discuss the important topic in venous system, that is deep vein thrombosis. So when we read Valian Law gives more focus on deep vein thrombosis rather than on varicose veins. So the most common clinical presentation of deep vein thrombosis is pain and swelling in the cough. Please don't forget, pain and swelling in the cough is the most common clinical presentation. The interesting point is it is usually mostly unilateral. So deep vein thrombosis is not bilateral mostly. It is usually unilateral, pain and swelling in the cough, unilateral, and it will have only low grade fever, not high grade fever. They will present you with a low grade fever only, not with a high grade fever. Okay. Now let us discuss the points from Valian Law in deep vein thrombosis. So deep vein thrombosis, let us assume a patient comes to you with a left leg pain with a low grade fever. What is the most common site of DVT? Most common site of DVT is cough veins. So please don't forget, the most common site of DVT is cough veins. Okay. Most common site of deep vein thrombosis causing pulmonary embolism is femoropopliteal veins. From femoropopliteal veins, we commonly get pulmonary embolism. The major fear in a deep vein thrombosis we have is pulmonary embolism. So the most common site of DVT is cough veins. Most common site of DVT going for pulmonary embolism is femoropopliteal vein, space from where the pulmonary embolism commonly happens. So at this point of time, already we have discussed the signs of DVT. Can you tell me what are the signs of DVT? Homan sign, forcible dorsiflexion, Homan sign should not be done. Compressing the cough aggressively, vigorously like this, Moses sign should not be done. But all you want to do, you can do only lateral compression, that is known as Pratt sign can be done. Pratt sign can be done. Or else use the elastomer bandage fully and ask him to walk. Subjective test, Perthes test. Or put a single tourniquet below the saphenofemoral junction and ask him to walk. You will see the enlargement as well as pain. Modified Perthes test, both subjective and objective test. So these are the three important things we still follow for diagnosing DVT by a clinical method. So at this point of time, you should know what are the causes of DVT. Causes of DVT. So causes of DVT, I'm just discussing ditto from Valian Law. What is that in Valian Law? So let me tell you, this is patient-related factors. Patient factors is the first thing. Second is the diseases. So these are the two headings from Valian Law. Patient factors are old age, obesity, immobilization, patient who is immobilized, pregnancy and purpurium, very important causes, pregnancy and puerperal period, okay, and high dose of estrogen therapy. So these are all related to female, that's why I'm putting together. Pregnancy, purpurium, estrogen therapy given, and previous history of DVT, and patients who are having thrombophilia. I will discuss about thrombophilia separately. Thrombophilia disease, patients who are having thrombophilia disease. And what are the diseases associated? So the diseases associated are trauma surgeries, trauma to the patient, or surgery to the bone fractures, orthopedic fractures, trauma and surgery to orthopedic fractures, and patient having malignancy, heart-related problems like failure. The heart will have failure, or there will be MI, or there is inflammatory bowel disease, nephrotic syndrome or renal failure. CVA patients, paraplegia patients, so inflammatory bowel disease, nephrotic syndrome and renal failure patients, paroxysmal nocturnal hemoglobinuria, homocystinuria. So all these are various causes. All these are various causes. Homocystinuria, paroxysmal nocturnal hemoglobinuria. All these things are leading to one triad. The triad is known as Virchow's triad. So Virchow's triad of thrombosis is characterized by stasis. Stasis in an immobilized patient who is immobilized. Surgery being done. Stasis. Hypercoagulable states. There is a hypercoagulable states like various thrombophiliacs, and stasis, hypercoagulable state, and endothelial damage. When these three together forms, there will be DVT. Stasis, hypercoagulable state, and endothelial damage will result in DVT. And at this time, you should know what are the causes of thrombophilia. So what is thrombophilia? These are a group of diseases which can cause thrombosis. Diseases which can cause thrombosis and hypercoagulable states. Hypercoagulable states due to thrombophilia. What are the thrombophilia causes? Congenital thrombophilia causes and acquired causes. So congenital causes are antithrombin 3 deficiency, protein CS deficiency, factor 5 Leiden deficiency, okay, lupus anticoagulant present, protein CS deficiency, dysfibrinogenemia are the congenital causes of thrombophilia. Acquired causes include antiphospholipid antibody, and presence of again lupus anticoagulant can be positive. Lupus anticoagulant and antiphospholipid antibody are the various causes of thrombophilia. So these are the various causes of DVT. So what are the predisposing factors? And the risk of DVT is mainly why we are discussing in surgery is the risk of DVT we are discussing in surgery because it is caused by many surgeries. So which are the surgeries which have high risk? This question is expected MCQ for you in upcoming exam. High risk surgeries for DVT are, so any urological surgery, any urology surgery above 40 years, any abdominal surgery, any pelvic surgery, orthopedic surgery. So these are all high risk surgeries. So abdominal surgery, pelvic surgery, urologic surgery above 40 years. High risk. Moderate risk surgery are nothing but general surgeries. General surgery above 40 years, Patients on OCP going for surgery, surgery lasting for more than 1 hour. Please remember, more than 1 hour, any surgery lasting is a moderate risk. So this is the advantage of doing fast surgeries. The major advantage of doing fast surgeries, if your surgery is going on extended, there is a moderate risk of DVT, moderate risk. And who are all the cases who have low risk? So low risk is seen in other uncomplicated surgeries, any uncomplicated surgery in age less than 40 years. Uncomplicated surgery in age less than 40 years, and surgery duration is less than 30 minutes. These are all cases who have low risk. So risk of DVT, high risk, moderate risk, low risk. So all super specialty surgeries like urology, GIT, pelvic, orthopedic, all these guys will have high risk, and any surgery extending above 1 hour will have moderate risk. Okay. At this time, I want to bring out one important question asked in NEET PG 2020, that is modified Wells criteria. Please don't forget modified Wells criteria. Modified Wells criteria of deep vein thrombosis, you should not forget. So modified Wells criteria to diagnose for predicting. To predict DVT, we have certain points given, and based on those points, if the total value is -2 to 0, it is low probability. Based on those points, I'm going to tell now, if it is -2 to 0, it is low probability. It is 1 to 2, that is moderate probability of DVT. If it is more than 2, it is high probability. So this is modified Wells criteria to predict DVT based on the following factors. What are the factors we included are lower limb injury. Patient having a lower limb injury, or patient had a surgery, or patient is immobilized in plaster. That is a history of lower limb injury or some surgery or immobilization in plasters. We give one score. Bedridden patient, bedridden for more than 3 days, or any surgery in less than 4 weeks. So patient is admitted in the bed for 3 days or surgery done within 4 weeks. We give one more point. So now come to the clinical examination. On clinical examination, patient having tenderness along the femoral vein or popliteal vein. There is a swollen limb. There is a cuff diameter. The cuff level, when you measure the diameter, it is more than 3 centimeter of opposite limb. Compared with opposite limb, it is more than 3 centimeter. There is pitting edema. Dilated superficial veins present, not varicose veins. Dilated superficial veins. The superficial veins are dilated. So on clinical examination, if you see tenderness, give 1 point, swollen limb 1 point, cuff diameter 3 cm, then opposite limb 1 point, pitting edema 1 point, dilated superficial vein 1 point. So these are the clinical examination points. Other history related, you should ask history. History of DVT. Patient had previous history of DVT. Patient has history of malignancy. Patient has history of drug abuse. So malignancy, history of DVT, all these guys will have 1 point, and drug abuse will have 3 points. So this is an expected MCQ. Who will have high points? History of drug abuse is 3 points. Alternate diagnosis is more likely. For example, alternate diagnosis, unlike DVT, this looks like a trauma or something else. Alternate diagnosis more likely. It doesn't look like a DVT. It looks like something else, means you have to put -2. So with this score, now you have to count this score. So lower limb injury or surgery or immobilization or bedridden for more than 3 days or surgery within 4 weeks, you all give 1 point. Tenderness, swollen limb, cuff diameter increased, pitting edema, dilated superficial vein, all these are clinical points. All these are history of DVT, history of malignancy, history of drug abuse. Alternate diagnosis more likely. With this, you come to a conclusion. Low risk is -2 to 0, 1 to 2 is moderate risk, more than 2 is high risk. So more than 2 is high risk. The question came in NEET PG 2020 is high risk. High risk of DVT after the exam. So we are very much worried about DVT only for pulmonary embolism. DVT going for pulmonary embolism is what we are very much worried. How to predict this? Whether DVT will go for pulmonary embolism or not is predicted by another score. What is it? It is also modified Wells score. There are 2 modified Wells criteria. So please remember, that's also modified Wells criteria. So what is asked in this? This is very simple. Unlike that score, here if the score is more than 4, it is suggestive of pulmonary embolism. Less than 4, less likely to have pulmonary embolism. So if the score is more than 4, there is more chances of pulmonary embolism. Less than 4, less chances of pulmonary embolism. What are the features? Clinical examination, signs and symptoms. What we examine, no, all those are predicting of DVT. Okay, all clinical signs and symptoms predict of DVT. 3 points are given. Alternative diagnosis less likely than DVT. So mostly it is a DVT. That means you have to give 3 more points. So we have to now look for pulmonary signs. Heart rate more than 100 per minute. Patient having hemoptysis. Heart rate is increased, and patient has history of immobilization for more than 3 days or surgery done within 4 weeks. The same point which we discussed already. Immobilization for 3 days or surgery done within 4 weeks. Or patient having history of DVT, previous DVT or pulmonary embolism, history of malignancy. So all these patients will have different scores. So no need to remember every score. It is actually difficult to remember. So just remember the scores that are having highest point are signs and symptoms of DVT 3 points, alternative diagnosis less likely than DVT 3 points. When the score is more than 4, it is suggestive of pulmonary embolism. In this modified Wells criteria, what are all included is these are the points included. We include heart rate, we include hemoptysis, we include immobilization for more than 3 days or surgery done in less than 4 weeks. And history of DVT and pulmonary embolism and history of malignancy. All these things will be included, and we calculate a score and find out a pulmonary embolism. So now coming to the prevention of DVT. So what I should do now is I should do treatment to prevention of DVT. So the best method is to prevent the DVT rather than to treat a DVT. So prevention of DVT is by mechanical methods and pharmacological methods. There are 2 methods, mechanical and pharmacological. Mechanical method is yearly mobilization. Yearly mobilization of the patient is advised. And we have to put pneumatic compression device stockings. After surgery, we have to put pneumatic compression device stocking, which will continuously massage the leg so that the veins will not get stasis. So yearly mobilization and pneumatic compression device. So pharmacological method is best to prevent DVT. Please remember this question came in exam. Which among the 2 is best? Means pharmacological method is best to prevent DVT. What are the pharmacological methods? The pharmacological methods we are using is injection heparin. Previously we were using heparin, but the problem with heparin is we have to monitor APTT. Activated partial thromboplastin time should be monitored. Therefore, now came the new drug injection. Low molecular weight heparin is started. No need to monitor anything. So no need to monitor anything in using of low molecular weight heparin. So low molecular weight heparin is used for prophylaxis. Please remember this point here. I want to tell here. Warfarin is not used for prophylaxis. It is only used for treatment. Warfarin not used in prophylaxis. We use either normal heparin or low molecular weight heparin. Warfarin is not used in pharmacological prophylaxis. Warfarin is used only in the treatment of DVT. In the treatment of DVT, initially for the first 5 days, we give heparin plus warfarin. In the treatment of established DVT patients, first 5 days, 1 to 5 days, we give heparin plus warfarin. After 5 days, we slowly stop heparin and give only warfarin. But when we are giving warfarin, we have to be very careful. We should monitor the prothrombin time, also known as INR, should be monitored. Prothrombin time or INR should be monitored to prevent toxicity of warfarin. Okay, we have to monitor warfarin toxicity by measuring prothrombin time and warfarin. If this is the first episode of the patient, we can give them 3 months warfarin is enough. If it is a recurrent episode, please remember, if it is a recurrent episode, we should give lifelong warfarin. We have to give lifelong warfarin. So first episode means 3 months of warfarin is enough, but it's recurrent again and again. We have to give them lifelong warfarin. Will you use thrombolytic drugs? Thrombolytics are not usually advised for cough vein DVT, but it is used for iliac vein involvement. For iliac vein involvement, we can use thrombolytic agents like alteplase, streptokinase. Those drugs for iliac vein involvement, we can use thrombolytics. So let me at this point of time tell you a few points about INR. INR, international normalized ratio, is equal to prothrombin time of patient divided by prothrombin time of control, a normal person. It should be normally 1 to 1.1. 1 to 1.1 is a normal value. Usually INR is 1 to 1.1. So if the INR is, please remember, if INR is more than 1.4, no surgery advised. If INR is more than 1.4, we cannot do surgery. Surgery is advised only when it is less than 1.4. If it is more than 1.4, I should give FFP before surgery. Fresh frozen plasma should be given before doing surgery. So if FFP is more than 1.4, we cannot do surgery. It will bleed like anything. Such cases, we should transfuse FFP, then only I should do surgery. In a case of DVT on warfarin patients, what should be the target INR? The target INR in a patient with a DVT will be around 2 to 3. 2 to 3 is a normal target in DVT cases. In cases of heart valve patients who are having mechanical heart valves, they will also be on warfarin. They should have 2.5 to 3.5 target value. So INR is used to maintain the blood and liquid state in heart valves and in DVT patients. In DVT patients, you should keep it at 2 to 3, and in heart valve surgery done patients, it is kept at 2.5 to 3.5. Please don't forget these points. So what is the use of INR? You should not forget. And coming to the surgical treatment of DVT, surgical treatment is number 1. We can do thrombectomy. So we can do thrombectomy. If it is a huge thrombus in the iliac or femoral veins, we can open and remove the thrombus. And after removing the thrombus, we can even keep a IVC filter known as greenfield filter to prevent furthermore thrombus going up and causing pulmonary embolism. After removing the thrombus, we can keep a greenfield filter. This is one method. Or else we can do a bypass. Bypass operation can also be done. What is this bypass? For example, if I'm drawing, this is common iliac vein, this is external iliac vein on right side, this is femoral vein, this is femoral vein, this is long saphenous vein. So now let us assume this patient is having a thrombus in the iliac vein level like this, having a thrombus like this on the iliac vein like this. So what I can do is, without worrying about the thrombus, I can bring this saphenous vein and anastomose here like this. So to the deep vein. So what will happen now? The blood from the deep vein will flow through the opposite side saphenous vein and go like this. Will go through the opposite side saphenous vein inside. So this operation is known as Palma operation. This operation is known as Palma operation. Palma. So it's a bypass operation. Instead of going and removing the thrombus or an established thrombus, we can do a bypass known as Palma operation. So please understand, this is a type of filter we keep it in deep vein known as greenfield filter. The main indication is number 1, when the anticoagulants are contraindicated. Example, where are the basic anticoagulants are contraindicated? Like in patients who are having cerebral hemorrhage. Patients who are having cerebral hemorrhage, we cannot give anticoagulants. Such patients we can give a DVT filter. And a patient with a DVT with anticoagulants developing pulmonary embolism, recurrent pulmonary embolism, such patients also we keep this. To prevent pulmonary embolism, we keep a greenfield filter. Please don't forget. Okay. So at this point of time, I want to tell some syndromes. May or Kuster syndrome. What is May or May? Yes, May Turner and Cockett syndrome. May Turner and Cockett syndrome. What is this May Turner Cockett syndrome? To understand this syndrome, you should understand this picture I'm drawing. This is common iliac vein, this is right common iliac vein, this is left common iliac vein. This is May Turner Cockett syndrome. In this syndrome, if you see, this is aorta, this is right common iliac artery, this is left common iliac artery. Here you can see the right common iliac artery is running on the left common iliac vein. So right common iliac artery compressing the left common iliac vein, resulting in clinical features like DVT. Resulting in clinical features like DVT is known as May Turner and Cockett syndrome. Resulting in clinical features like a DVT is known as May Turner Cockett syndrome. Please don't forget this syndrome. So the next syndrome is phlegmasia alba dola. Phlegmasia alba dolans. This is nothing but white leg. What do you mean by this phlegmasia alba dolans white leg? In this condition, the deep veins are thrombosed. Please remember, the iliac vein, femoral vein are all thrombosed. Luckily, superficial veins are patterned. So therefore, the blood is flowing and therefore the leg is white color. One more condition is phlegmasia cerulea dolans. What is it? Cerulea dolans is blue legs. This is known as blue legs. So phlegmasia cerulea dolans is blue legs. In this condition, deep veins are thrombosed. Superficial veins are also thrombosed. Interesting point is both deep vein and superficial vein both are thrombosed. So therefore, the leg is in a gangrenous stage known as venous gangrenous stage. I will show you the images of these two. So venous gangrenous stage. So phlegmasia cerulea dolans is an emergency. It's an emergency. Immediately we have to go and do surgery. Otherwise, the limb will be gone. Immediate surgery needed for phlegmasia cerulea dolans. Okay, let me show you the images. So they are more commonly phlegmasia cerulea dolans is more commonly seen in malignancy cases. So please don't forget they are commonly seen in malignancy patients. So all these points we have discussed. Please don't forget there are two modified Wells criteria. One to predict DVT, another to predict pulmonary embolism. Pulmonary embolism, when the score is more than 4, it is more chance of pulmonary embolism. Less than 4, less chance of pulmonary embolism. So high risk of DVT is present in modified Wells score when the score is more than 2. Okay. So this is a DVT in a venography. Investigation of choice for DVT is color Doppler duplex scan. Okay. And this is a pneumatic compression device shown here. Already asked as image question names. Please don't forget pneumatic compression stockings. So pharmacological methods are more effective. So please don't forget this is a thrombectomy procedure going on one of our hospital older patient. The thrombus is opened and removed and you can see inside a greenfield filter is kept inside. So this is a Palma operation. The iliac vein is compressed here. The opposite side saphenous vein will carry the blood in this way like this. So this is a Palma operation. So please don't forget this is greenfield filter. So May Turner Cockett syndrome is left common iliac vein compression of left common iliac vein. So this is a white leg. You can see here not much dangerous. It is seen in pregnancy and underlying malignancy, milk leg or white leg. Cerulea dolans is more commonly seen in malignancy. You can see the entire limb is gone for gangrene. It needs immediate surgery. It is a blue leg. Phlegmasia cerulea dolans is a blue leg. Alba dolans is white leg. In alba dolans, superficial veins are open or patterned. Whereas in cerulea dolans, both superficial and deep venous system are occluded. More emergency. Okay. So this is about the DVT. Please don't forget this chapter. Venous system is given more concentration in recent years. I request you to thorough this chapter in depth. Okay.